Hello, Bruce Arrell's my name. I'm a professor of general practice in Auckland, New Zealand, and it's my great pleasure today to be interviewing my friend of almost 30 years and colleague, Ngaire Kerse, who's a professor in the Department of General Practice and Primary Care at the Auckland University. So welcome, Ngaire.
Hi, Bruce. How are you going?
I'm going very well. Well, I guess I'd like to start with how come you ended up at medical school, and then maybe how you ended up in primary care, and then you ended up with your gerontology focus. So maybe three questions in
Right.
one to get you started.
Okay, well, I grew up on farms in the South Island. I was born in Gore, which is away down the south of the South Island, and small farms outside there. I'm number 6 of 7 children, and I was the sick one. I had really bad asthma and in and out of hospital till I was about 5. And when I was 7, they discovered sodium cromolyn, which was the first sort of preventer, and that changed my life. So that, I think that might have been one thing. And then when I was in high school, I was a nerd. I definitely could do stuff that the other kids couldn't do. And so I got this idea. And then, of course, as in small country towns in New Zealand, of course, in those days, which was the 60s and 70s, everybody went to church. And so we had a lovely minister, and he was great. And he said things like, you should fulfill the best roles that you can. Otherwise, and so I began to think, well, maybe I could go to medical school. What I really wanted to be was a rural land valuer, because I really liked the country and I really liked climbing hills, and rural land valuers got to go and do all those things around in the country. But anyway, I ended up trying for medical school because I had this weird notion that if I didn't do it, I probably could do it. I realized that if I didn't do it, I'd be taking someone else's job. So it's not a really positive reason. And then once you get into medical school, it's very hard to change your mind and get out again. I kind of admire people who do that. And so as we went through, we did have a crisis. My mum got cancer and died at 3rd year. I failed 3rd year of medical school. And then I went to Auckland Medical School, which is in the north, which was very unusual for my area. By then, we were living in Geraldine in the middle of South Canterbury, just south of Christchurch. And that was where high school was. And so I got into medical school, Auckland Medical School. I transferred medical schools to Dunedin halfway through because of mum's illness, and she died anyway, to be closer to dad and all the rest of them. So those two things had a pretty big impact on my life. The decision to go to medical school, I think, was seriously influenced by my childhood illness, which now is fine. Here I am. I'm got my gold card this year, and it doesn't bother me at all because of the amazing advances in medical practice to do with asthma. So I'm rambling, sorry, but so I got into medical school by that nice rural upbringing. Went to medical school because I got in. Once in medical school, the choice for gerontology was really not made for quite some time, but my grandmother seriously influenced that choice. Grandma was a lady who had supported all her life my grandfather, who was bipolar. And of course, if you think back to this is the 1930s and 40s, there wasn't really much treatment for people with bipolar disorder. So he would just go mad and end up in the asylum with all of those things that are associated with that. And then he died, and Grandma was the most independent, kind, wonderful person you can imagine. She would, my mum would arrive with these 6 kids. We were all pretty energetic. And that relationship with her carried on right through university. So I would then arrive at Grandma's with a bunch of, 6 people. We were tramping in the Cobb Valley, and we'd come back from tramping and we'd find that Grandma had mended all of the shirts and sewed all the buttons on and done all the washing and had all her stuff ready. She got to be 95 and was independent very much until the end. So I was always fascinated by that. After medical school, I met my now husband, and we went to Philadelphia for his PhD. And in Philadelphia, I took the opportunity. I have to say it wasn't really that way intended, but when you go to America, you get your visa, and I was a foreign a non-resident alien for all of the years. We were in America, 6 years. And so you could work in a training agency, but you couldn't work in private practice. So I did my family medicine training program, which was great. And then by the time I'd finished that, I thought we were going home, but Simon hadn't finished his PhD. So I had to choose something else. And the choices were either hospital administration or geriatrics. So I think that was an easy choice for me. So geriatrics was the thing. And I kept thinking back about my grandma and that Geriatric Medicine Fellowship for 2 years provided research training. And that's when I got really interested in research. And I was just fascinated by the questions that you could answer and how you could answer them. And I also knew that from a population perspective and from my experience growing up, that actually the GPs in primary care was really, really important. So I wanted to stay in primary care because that's where you kind of have the whole person. You don't just have a little slice of the person. And then the older people were just so gorgeous and complex and challenging. And I really enjoyed working with them. So I ended up, after that fellowship, coming back to New Zealand, which I thought would be forever. Of course, we stayed a couple of years. I did the GP training here. And then we went to Australia because my other half was headhunted to a postdoc position there, but I ended up in that wonderful University of Melbourne area. So I then did a PhD there, and I did that PhD because when you're a busy clinician, you have lots of questions. You don't really have time to sit down and think about them. You don't really have time to engage in research. I'd had this research training. I had written some papers. I got fascinated by even the writing process and started applying for grants. And I just got hooked on the academic pathway. And so I did a PhD to try out the research lifestyle to see whether I really liked doing research. So I did a clinical trial with GPs and older people about education, about health promotion, about trying to improve the health behaviors of older people. And by influencing the GPs, I discovered that older people did respond. And I really enjoyed the research track. So then I chose an academic track in universities, always with general practice, clinical practice alongside. And I've made that work. Came back to New Zealand last century in 1999, and I've been at the University of Auckland ever since.
So just looking at what you learnt about research, I often think what a PhD does for you is it teaches you to be a better researcher. People think it's a ticket, but actually, well, it is a ticket, but it also makes you a better researcher. I'm curious to know what you found helpful out of doing that PhD in terms of content or methodology or whatever. What did you have at the end that you didn't have at the beginning?
So the PhD, of course, is a journey, and the journey is different for everyone. I was very fortunate to be in the University of Melbourne, and I had a group of people around me who were all doing PhDs. There must have been 6 or 8 of us, and then we called in other people. We formed the Pickles Club. If you know, William Pickles was a famous GP academic and primary care researcher. And that was Jane Gunn, who's now the provost of the University of Melbourne in an acting capacity, but she's been the Dean of Medicine there. And some various others, including, and we'd invite Nick Blasio down from Brisbane and Chris Del Mar to come and give talks. And it was a very supportive environment and very exciting. And we had lots of discussions about methodology. I was passionate about randomized trials. I still am, but they have a place. They're not everything. And so the milieu of researchers and milieu of research advice there was very good. So I think the PhD emphasised that you need people around you while you're doing your research to spark new ideas and also to give you the right kind of advice. I've always had a biostatistician advisor in everything I've done because I don't have that skill. I think I do, but I don't really. And I've always tried to put together the best teams. And so sometimes the teams for my research are really large, and that's good and bad. The focused attention to one topic is what I learned, and that was very good. The focused attention to one topic. I think that's the only time in my whole career I've been able to do that. And so it was a good clinical trial. It got published in the BMJ. Isn't that good? And then that was helpful. All of that was helpful in coming back to an academic position in New Zealand. So the PhD, I think, is in a very important training ground. I didn't take any courses during the PhD, but that was because I have felt I had adequate research training methodology-wise, you know, in clinical epidemiology and epidemiology, which was the methods I was using. I do think you need formal training in the methods of your PhD, whatever it is. I felt like I'd had that in the clinical fellowship from the States. So, and I do think that I learned a lot about analysis and how to make data work, and all of the ins and outs of that data analysis, as well as, I think, interpretation of things and putting it in the bigger perspective. And I do think that people need to present their work and be in active discussions with other people about that work to understand where it fits in the wider view of health and research and whatever discipline or area that you want to influence.
And just looking back on your career, it sort of marked a big sort of U-turn in the department, I think, because you were the first person who'd done a PhD in a primary care department. I'd done mine in a public health department, but you've done it in a general practice department. And that was a big sort of shift.
That's a big perspective.
The clinician doing research. So you were the start of the modern primary care academic in New Zealand as we understand them now.
Gee, thanks for that, Bruce. I wasn't aware of that, but I guess that's right. And I think that was the benefit of coming from the department in Melbourne, of course, was a few years ahead of us because they had been a department of general practice and public health, and they'd split to be just general practice. And they had Doris Young, who was a strong leader, and other people coming up through. So I was quite comfortable with general practice being a thing in itself, primary care being the focus, didn't need to be supported by other self-disciplines. So I guess that's what I carried on. And I think, I mean, I was young and energetic. And so I wrote lots and lots of grants. And because you write lots of grants, you get better at writing grants and you start to get them and other people see that success. And I think that that kind of role model thing I know was probably quite important throughout the first 10 years that I was there. You know, during those 10 years, I also got the opportunity to do a Harkness Fellowship, and that was interesting in itself too. And that took me back to Seattle for a year. Now, as you might remember, we had all those years in Philadelphia. That was the East Coast. Now, Seattle, the West Coast, you know, my experience with America is long and in depth, but I still think it's a real enigma. I do not understand it. It is so different and diverse in the different states that you're in. The rules are different, the people are different, the ways and understandings of working are different. And delivering medicine in America, of course, during the Harkness, I didn't deliver medicine as such, but when I was training as a GP, as a family medicine resident and a geriatric fellow, the expectations of the population were quite different about their health and about the levels of investigations. And, you know, that made me realize that actually there's really different ways of practicing medicine in different places. And you don't really understand that unless you go somewhere else. So I think it's actually very good for academics, clinicians, specialists, specialist general practitioners, nurse practitioners, everybody to actually try out a different health system just to really understand the benefits of ours. And I think our health system is world leading. I think it's fantastic. I don't know why we get such shtuck about why it doesn't work. It's so much better than a lot of other places. So that being practicing in Australia and America really gave me a perspective about what primary care was and could be, is and could be. And made me think about that in the care of older people. There's another whole bag of worms. You know, in Australia, you've got federal, Commonwealth and state funding for different bits of what happens to older people. In America, you know, older people really don't get funded very well. In New Zealand, we do have a comprehensive health system and most things are available. It's just clunky. So yeah, I've also lived for my sins in Newcastle for 6 months in the UK and Leiden in the Netherlands, and understand about those health systems. And each health system has its really intriguing, interesting things. Some are better, some are worse. Made me want to, I talked to Tim Benzel in our health systems area because he's the health policy person in our university, and I can have good discussions about that, and I think that's really important too. So I guess as I've gone through the different stages, the breadth of experiences has really helped me understand and potentially write better.
All that international experience puts you on the international stage, which I often say to the young docs working with me, at some point we need to get you on the international stage. How are we going to do that? And by doing all that overseas stuff, you automatically, any comments on that, the importance of that internationalism as an academic?
Look, I think that I was so fortunate in having that early exposure to overseas. I didn't realize its value or its worth until sort of now. And certainly when I went back on sabbatical, I think sabbatical is really important for academics to be able to go somewhere else and experience something else, recharge. Remaking connections from connections that I had was so much easier because I understood the landscape and knew some people. It is very hard to get to know people unless you go. I don't know what we're going to do because now we have a climate crisis, which means travel shouldn't be really done in the way that we did it in those days. I do think that it is possible to make connections overseas without going, but it's much harder. But the more now I'm sort of a senior academic, I'm much more interested in influencing what happens here now in my neck of the woods than in being a world leading academic. My university won't be happy with that, but I think that is because I understand the investment that's needed and the investment in time, energy, and thinking for our own populations. We have a very complicated older population in New Zealand between our growing Māori and Pacific elders and our burgeoning of the Asian older population who don't engage in health services and who we don't look after very well at all. So I'd like to contribute to international stuff from doing good research at home. Another famous academic, Ian Reid, said that to me once too. He said, you've got to be famous at home before you can be famous overseas. And so I think I got famous overseas before I was famous at home. So I was the other way around. So now I'm the Joyce Cook Chair in Aging Well, which is quite a prestigious appointment. It's a philanthropic appointment. And so now I have a bit more time and focus on the lot of older people and how to make sure it improves through time rather than getting worse. So public health. Oh, I was just going to say, for older people, the impact of public healthy type things, poverty is coming to our older age groups. How are we going to stop that? These are the things that I'm struggling with at the moment.
So it sounds like the next stage in your career is sort of changing the world and putting what you're doing into action. Would that be a reasonable summary?
Yep, I think that's a very good comment. So 25 years of generating original research, 300 papers, and I feel like nothing's changed. So now it's time to just focus on changing things. And so that's what I'm going to try to do. Do you know how to do that, Bruce? How do you change things?
That takes a whole different focus, I think. But I think part of us in the second half of life want to leave a mark on the planet. And you've got a fat H index now, and now you want to change the world.
I don't want to change the world, though, Bruce. I want to change the life of our people here in New Zealand. And maybe the world will see how, I'll obviously keep writing about it, but maybe they'll see that and realize that actually locally driven and designed and developed solutions, they have to be local. You can't impose things from overseas on people because often it doesn't work because the understandings in the health system and the drivers and all of that are different.
And that context is completely different too, isn't it? So along those lines, what are, say, 2 or 3 things that you know now that you didn't know when you started out? remember the thing about elderly Maori, they didn't know what depression was, those Maori women,
Yeah,
when you
that's
asked.
right.
I mean, I thought that was
Yeah,
amazing. They live
yeah,
rurally, and they didn't really have a concept of it. It wasn't a thing for them.
that's right. So I think that the LiLAC study, so you can look it up, LiLACs NZ, Te Puawa Tangau to Tapawai Ki Ora Tonu, the flourishing of older people, and is a 85 plus study. There are a group of 85 plus studies around the world. We started with looking for 85-year-olds exactly in one regional area. We were, of course, wanting to do the right thing in our tumuaki or Māori lead. Papa Rangi Reid said you have to have equal numbers so that you can do analyses for Māori that are good and have integrity for Māori. So we had two cohorts actually. There were enough Pākehā at age 85, but for Māori, they're a smaller percentage of the population. At that time, there were about 6.5% of the population over 65. So we broadened the age band from 80 to 90. So we had about 400 Māori and 500 non-Māori. And then was a cohort study. So we measured lots of things, 9 hours of interviewing, assessing blood pressures, script strength, a lot. Followed them through every year, interviewing for 5 years, and then a 10-year final follow-up. And so what we learned, every analysis that we did, what we expected in the analyses, what predicted the outcomes was as expected for Pākehā, for the non-Māori, but there were different drivers amongst Māori. The qualitative aspects, we had a wonderful PhD student, Marama McDonald, who interviewed older Māori. She started out wanting to interview about depression, but that just had no salience for Māori. So it turned into an interview about happiness. And yes, it did uncover a framework of aspects which influence well-being or psychological well-being or happiness. But the concept of depression was just wasn't relevant, actually. And so that came through in several other analyses as well. And of course, the measures that we used were Western developed measures. The cognition measure was the 3MS. The depression measure was the GDS. The physical activity measure was the physical activity, the pace measure. And of course, those things work for Pākehā because that's where they were generated from, but there were different things influencing those aspects for Māori. So from that study, Makarena Dudley, fabulous Māori, the neuropsychologist went ahead and developed a Māori cognitive assessment tool called the Mana tool, which probably is much more accessible and does describe dementia very well for Māori. And there's been lots of other aspects like that. So I learned that your expectations from one cultural group can't be transposed upon another cultural group. You really have to understand that cultural group from the bottom up. We have wonderful Māori researchers who are doing that. They need more resources and more time. And I was also so respectful and so admiring of the older Māori in that project because they were resilient, they were welcoming, they were generous. The questions we did ask them, the Māori were much more likely to be contributing financially and, of course, language and culture to their mokopuna, to their grandchildren, than the non-Māori. And yet the Māori were much more economically disadvantaged, lived and had lower incomes, had less savings, etc., etc. So they had a really different view of material wealth because it was not as relevant to their well-being and to their societal success, certainly as it is for Pākehā. So I don't want to denigrate Pākehā at all, but I'm just saying that, you know, we understand now that things operate, in fact, that risk factors and influences operate differently in different cultural groups.
And the word Pākehā in New Zealand is Māori for European. So
that's right, the word Pākehā, so the non-Māori, so the European of, and of course, I think Pākehā means that you are a European descent person in New Zealand. I think it's different from somebody who just moved from Scotland or England because they haven't got the New Zealand influence. Growing up as a European in New Zealand changes you very differently from growing up in the UK. I don't know if you had that experience when you went to Canada.
It takes a while to become part of the backdrop. So
yeah.
So Ngaire, I think we'll call it a day there. and it's been fabulous having you as a friend and colleague for this past 30 years, and I look forward to the next 30 years.
Probably 30, Bruce. We're in for it. We're successfully aging, that's for sure. Yeah.